Invitation. I will show you a TAVI case in a bicuspid aortic valve with horizontal orientation. So it was a 70-year-old male patient, bicuspid valve, horizontal orientation of the aorta with severe stenosis and moderate insufficiency. He had a history, he had prostate cancer without treatment. So far it was diagnosed some days before he came to the hospital to treat the aortic stenosis. During the angio we found a severe middle AD stenosis, and he was a previous alcoholic patient. So we did the heart team and with a cardiologist, heart surgeon, and oncologist. And the decision was first to treat the LAD with PCI, then implant the TAVI, and then proceed with hormonotherapy for the prostate cancer. It was, as you see, very, sorry, this is the ballooning. In the second picture, you see the result of the PCI. Sorry, I don't know what's happening here. Other videos are coming up. Anyway, you see the valve characteristic. The annulus perimeter was 24.1, and the angulation was 64 degrees. You see here in the CT scan that there's a rapha between the right and left coronary cusp and the horizontal aorta. We had very much difficulty in ballooning this valve. We tried more than 10 times in order to have a good balloon position. The implantation was quite easy. It was performed under pacing at 120 beats per minute. You see the pigtail is positioned in the right coronary cusp and not in the coronary. But since we had a good visualization of the non-coronary cusp, we didn't change the position. And the final result was that. So 1 year after follow-up, he had excellent valve performance, no angina, and normal PSA after hormonotherapy. In conclusion, accurate neo implantation is feasible and safe in patients with complex anatomies. And we weight the new size of accurate neo, the 29 millimeters, the extra large valve, that will give us new option in treating patients with a larger annulus. Thank you very much.
Thank you, Michael. Excellent result. Bicuspid aortic valve. How do you decide to put an accurate?
You know,
the experience is low. I think.
The experience in general with accurate in bicuspid valve is low, but because we use it as a main valve in our team, we said that we will. Okay, we are a low volume team. We performed last year 30 TAVI. This year we hope that we will perform 50.
We feel confident to put. You feel confident.
We don't like to deal with many valves. Yeah. So we have a program that we say we will put 2 valves in order to cover 100% of the cases. We have a self-expandable valve that is accurate neo, and a balloon expandable valve that is Edwards.
And you put in the same way, the same landmarks as in
the same landmarks. We do pacing in all bicuspid, and actually, because they are very calcified, sometimes they allow a more high implantation. The calcium lets you. It will grab the valve, so you are not much concerned about the high implantation. You are more concerned rather for the low implantation, I can say.
Professor Hamilos, do you have any comments?
I would like to congratulate Michalis for this very nice case. His skills beyond the CTO goes now to the aortic valves as well. I have to say that I understand his choice more or less because he has experience with Acurate. Also, there was very horizontal aorta, which maybe is Acurate could be a good choice. And I didn't see the CT, Michalis, if you had calcium in the LV outflow.
No, no calcium in the LVOT.
So this makes your life a bit easier in such cases. And I have to say that the result is, from what I saw in the aortogram, is fantastic. It is very good without any regurgitation. So it proved to be a good choice finally. Another option would be also to put a balloon expandable valve, but okay, this was a very good result.
Dr. Koutouzis. Thank you, Michalis.
Congratulations for the presentation. I guess another advantage of the Acurate valve is it's easy to reaccess the coronaries in case you have to control or retreat the patient.
That's true. But really, here in Greece we have some, not the teams that are performing TAVI are not very experienced. They don't have big volumes, we can say, compared to centers in other centers in Europe. So I think it's logical to try to minimize the number of valves used by every team, because you cannot know any valve very well.
You are correct, but you have to know at least two.
At least two.
Expandable,
at least two.
One self-expandable.
I agree. Thank you
very much for the case.